We'll start off with our case of a 4-year-old healthy girl who has had a 5-day history of fevers, non-bilious emesis, and non-bloody stools, complaining of severe abdominal pain. On physical exam, she weighs 15 kilograms, her heart rate is 176, her blood pressure is 80/40, her respiratory rate is 32, and her temperature is 35.3, with an oxygen saturation of 92% on room air. She appears lethargic, her abdomen is distended, firm, and diffusely tender. Her extremities are cool with a capillary refill of greater than 3 seconds. The emergency room got a CT, and in her pelvis, you see that she has multiple pelvic abscesses. Robert, after this child arrives to your facility, what would your next steps in her care be?
Along with diagnosis, a prompt determination of whether the patient is suffering from sepsis or septic shock is imperative. The key factors to obtaining the best outcomes in patients with sepsis is prompt recognition and rapid initiation of therapy.
So Robert, how would you make a quick determination of sepsis?
Traditionally, recognizing sepsis was based upon the patient meeting criteria for SIRS and then having a known or suspected infection. Depending upon the level of physiologic derangement, increasing severity of sepsis would be defined as severe sepsis or septic shock, noting that the presence of hypotension was not necessary to define septic shock.
So utilizing these SIRS criteria seems straightforward. Are there any issues in using these definitions?
Unfortunately, there is. In the adult population, the Sepsis 3 guidelines published in 2016 recognize that sepsis is much more complex than what a two-step algorithm can predict, and that this algorithm is actually neither sensitive nor specific. The definition of sepsis in adults has therefore changed. Sepsis in adults is now defined as any life-threatening organ dysfunction. A new category, sepsis-induced organ dysfunction, is defined as any acute change in the patient's SOFA score of 2 points or greater from baseline. Septic shock is defined as any instance where circulatory or metabolic derangements increase mortality. This terminology is actually what is used in the most recent pediatric surviving sepsis guidelines.
So this is an adult score, right? Are there any recognized issues in using this model in the pediatric population?
Actually, there are. The Sepsis 3 model utilizes clinical criteria to make the diagnosis. Therefore, each physician's judgment will alter diagnostics. Additionally, SOFA scores are better for prognosis than early detection. In addition to all of this, in order to utilize these metrics in the pediatric populations, age-adjusted SOFA scores must be defined and validated.
What are the best tools that we have available for the early detection of sepsis?
Recognizing that early diagnosis and therapy is key, sepsis bundles are the best instruments that we have available for the rapid detection and treatment of pediatric sepsis. In fact, some of the strongest data with regards to improvement in mortality in pediatric patients involves adoption of these bundles. Typically, there are 4 bundles used reflecting different phases of treatment: recognition, resuscitation, stabilization, and performance.
So what should be included in the sepsis recognition bundle?
The recognition or trigger bundle typically includes age-adjusted vital sign criteria, as well as patient-specific details to determine high-risk populations. Patients deemed to be at high risk for sepsis should then be rapidly assessed by a physician for confirmation. If suspected sepsis is confirmed, the resuscitation bundle should then be initiated. The AAP does have sample bundles available on their website. It is expected that each institution will tailor their specific needs and capabilities based upon these templates. In our case scenario, a patient with a history of fever and abdominal pain, now with hypothermia, tachycardia, and hypotension, as well as a suspected infectious source for these physiologic derangements, meets the criteria for septic shock.
So Robert, what would you recommend as the next steps in management?
Ideally, our institution would have a resuscitation bundle in place at the time of the patient's presentation. The goal is to complete the resuscitation bundle within 1 hour of identification of suspected septic shock. This is aimed at normalizing heart rate, blood pressure, and capillary refill.
Robert, can you tell me a little bit more about what interventions should be included in this resuscitation bundle?
The resuscitation bundle begins with quickly obtaining intravenous access. In the event of significant hypotension or dehydration where peripheral venous access cannot be obtained, intraosseous or central venous access should be considered. This is followed by fluid administration and initiation of broad-spectrum antibiotics When feasible, blood culture should be obtained prior to antibiotic therapy, but this should not delay antibiotic administration.
What are the details about fluid administration during the resuscitation period of a patient with septic shock that we should know?
Initial fluid resuscitation follows the 2017 ACCM guidelines and begins with 20 milliliter per kilogram boluses, either isotonic crystalloid or 5% albumin, and can include up to 3 boluses during the first hour of resuscitation. During this phase, hypoglycemia and hypocalcemia should be corrected, and a 10% dextrose-containing isotonic crystalloid should be started as maintenance fluid.
Are there any additional recommendations available?
Yes, the Pediatric Surviving Sepsis Guidelines recommend isotonic fluids such as lactated Ringer solution or plasmolite over normal saline, given the increased risk for acidosis. These guidelines also favor balanced isotonic fluids over 5% albumin, but this is mainly due to cost consideration and availability. Due to fluid overload, the Surviving Sepsis Guidelines also consider local resource availability when administering fluid. At institutions where intensive care units are not available, boluses should not exceed more than 40 milliliters per kilogram in hypotensive patients. And those patients without hypotension, only maintenance IV fluid should be administered.
So Robert, what are those signs of fluid overload that you may see during the initial resuscitation?
This can sometimes be difficult to determine. While classic teaching includes findings of pulmonary crackles or jugular venous distension on examination, these are often absent or late in presentation. Current recommendations include assessment for hepatomegaly or advanced metrics, such as finding distension of the vena cava or atrial distension on ultrasound.
If your initial fluid resuscitation is inadequate or fluid overload develops and there's still persistent shock, what is your next step?
If shock persists after fluid administration, a catecholamine vasopressor should be added. While the ACCM guidelines stratify warm shock from cold shock based upon clinical factors for peripheral perfusion, recent data suggests that cardiac dysfunction can occur even in the presence of clinical signs of warm shock. As a result, the Surviving Sepsis Guidelines recommend utilizing advanced hemodynamic monitoring, such as arterial pulse wave analysis, echo, or NIRS, to evaluate for warm versus cold shock.
So Robert, which vasopressor would you recommend we use first?
This is still a question that does not have a definitive answer. Current data suggests that epinephrine or norepinephrine should be the first-line vasopressor used instead of dopamine. There is also weak evidence that suggests that epinephrine may actually be better. Given our patient's presentation of being consistent with cold shock, epinephrine is likely the best first-line vasopressor to use. And given a need for vasopressor use, ICU admission is required.
How would you recommend we titrate vasopressors?
This is also a question that does not have a definitive answer. While ACCM guidelines provide details regarding titration of vasopressors, also known as goal-directed therapy, there isn't robust evidence to suggest that any predefined endpoints are beneficial. As a result, the ACCM guidelines should be considered recommendations only. The Surviving Sepsis Guidelines weekly suggest vasopressin as a second-line agent and trending serum lactate levels to measure the effectiveness of resuscitation.
What other steps are necessary in sepsis management?
A unique role the surgeon plays in sepsis management is source control. Whether this is personally completing surgical control of infection or coordinating percutaneous procedures, source control is of utmost importance in the septic patient. While it is common to try and wait until a patient is completely stabilized to undergo source control, this practice may actually prolong the septic response. Therefore, the Surviving Sepsis Guidelines recommend obtaining source control as soon as it is deemed feasible. This includes early removal of any proven infected vascular device, with the only exception in those patients with no other possible sites for vascular access. In our patient, the surgeon should work in concert with local resources for possible percutaneous drainage of the intra-abdominal abscesses as soon as she is deemed stable to undergo the procedure.
What if our patient, despite the mentioned interventions, remains in shock?
The ACCM guidelines provide an excellent list of possible causes of ongoing hypotension or shock despite fluid resuscitation and vasopressor use. These include inappropriate source control, tension physiology such as pneumothorax or pericardial effusion, blood loss, and adrenal insufficiency.
When should corticosteroid therapy be considered?
In patients with pre-existing adrenal insufficiency, stress dose steroids are appropriate. The use of corticosteroids in other scenarios is not as clear. The surviving sepsis guidelines recommend against their use when fluid and vasopressors are enough to treat septic shock. When fluid and vasopressors are insufficient, these guidelines are equivocal on their use.
If our patient requires intubation, what are the current guidelines?
Regarding mechanical ventilation, the Pediatric Surviving Sepsis Guidelines provide several recommendations. Due to the risk for adrenal suppression, etomidate should not be used for intubation. And while inhaled nitric oxide should not be used routinely in septic patients, it can be considered as a rescue therapy. For patients that develop pediatric acute respiratory distress syndrome, typical ARDS settings, including high PEEP, should be used, and both prone positioning and paralytics can be used in severe cases. They were unable to make any recommendations regarding the use of recruitment maneuvers or specific ventilator motives.
Do the surviving sepsis guidelines provide any recommendations about blood transfusions?
In the hemodynamically stable patient without evidence of bleeding, there are recommendations against transfusion thresholds for platelets and fresh frozen plasma. Similarly, for a hemodynamically stable patient, blood transfusion should only be considered if the hemoglobin is less than 7.
Are there any other recommendations from the new Pediatric Surviving Sepsis Guidelines?
There are actually over 70 specific guidelines provided. Some of the more pertinent ancillary recommendations include not withholding enteral feeding based solely upon ongoing vasopressor use and delaying TPN up to 7 days from admission in the well-nourished patient. Currently, there is no evidence that any special formulas or supplements, both enteral or parenteral, are of benefit in septic patients. In addition, the routine use of IVIG, stress ulcer prophylaxis, and DVT prophylaxis are not recommended.
So what about extracorporeal support modalities?
The surviving sepsis guidelines address plasmapheresis, renal replacement therapy, and ECMO. In the absence of thrombocytopenia-associated multiple organ failure, routine plasmapheresis in septic patients is not recommended. The guidelines are equivocal on its use when it is present. The Surviving Sepsis Campaign recommends utilizing low-volume renal replacement therapy for the treatment of or prevention of fluid overload. The recommendations for the use of ECMO in septic patients needs to be explained. In the septic patient, the exact indication for ECMO must be delineated prior to the initiation of ECMO therapy. For patients requiring ECMO primarily for pediatric acute respiratory distress syndrome, veno-venous ECMO is recommended. This is assuming that hemodynamic support and metabolic derangements do not need to be supplemented by ECMO. For those patients with septic shock refractory to all other treatments, veno-arterial ECMO should be considered. The best outcomes for veno-arterial ECMO in septic shock have been obtained in patients where ECMO flows were at least 150 milliliters per kilogram per minute, with questionable utility for ECMO in sepsis for those patients who could not obtain these flow rates.